termination level of use. Write it down, Onset, termination, level of use. The second has 3 words: onset, comma, termination.
Hello guys, hi, I'm Dr. Niklesh. I'm going to do pediatrics and obs and gynae for you today. So I think you might be tired. It's a long day today. Let's start with the stations quickly.
Fourth is tolerance.
So here you go, you have your first station. So you're an FY2 in pediatrics. Patient age 2 brought in by her mother because she had a fit. On examination, her temperature was 38.9 and redness over her left eardrum. Please talk to the mother and discuss the management plan. There you go. So when you say fever and ear pain, so what did the differential diagnosis will you get on your mind? So the first differential would be
the second point, which is
meningitis or anything, any pain or any fever then around neck or your ear. The first diagnosis should be meningitis, and then obviously if there is any ear pain, otitis media, and there is pneumonia, because sometimes pneumonia can spread to meninges and also your ear and can cause otitis media and meningitis. Then gastroenteritis is your form of DD. Once you have thought about DD, so now we have to think about some of the associated symptoms. So we have to think about associated symptoms and ask all the questions related to fever and pain, as this is febrile convulsions, and febrile convulsion is a diagnosis of exclusion. So you have to exclude all the causes of sepsis from maybe chest, maybe neck, meninges, maybe ear, or maybe any UTI. So any infection can cause fever, and fever in turn can cause febrile convulsions. So try to ask some history, associated symptoms regarding maybe headache or meningitis, maybe any cough or sore throat or runny nose, or any chest infection, or any dark colored urine or smelly urine for UTI in order to rule out any infection source. So as you have excluded us from the history that there is no source of infection, so now there is no proper source of infection. So now the diagnosis would be febrile convulsion. So what is febrile convulsion now? So febrile convulsion means any fits which is caused by increased temperature in the body. Right, and this condition, any fits and any fever, so once you have come to a conclusion that it is febrile convulsion, so now you ask some general pediatric questions like birth of the baby. So you have to, these are the general pediatric questions which might not be related to any particular station or any particular condition. So this you need to ask in every station. For example, birth of the baby. So you need to rule out some complications which might occur during the birth of the baby. So just ask a simple question saying, how was the birth of the baby when she was born? So the mother might give you some history relating to, was it a normal delivery, C-section, or any complications during the pregnancy which might lead into some infection after the birth. Right, and then any immunization. So try to ask, is the baby up to date with all the immunization jabs? If yes, then just ask for any recent immunization, because sometimes recent immunization can lead to some infection, and which in turn can lead to fever and then convulsions. And so There's one more important question which you need to ask in all pediatric cases is the development of the baby. So as you know, there are few developmental milestones which you regularly ask in any pediatric history taking, which might have gone through your medical school. So you ask how is the development of the baby, whether it is fine or any problems, did you notice any difference, maybe previously or during this illness. So what is this red book? So red book is a notebook which we use in the UK to note all the development of the baby whenever you visit a doctor. So he'll be examining you and they'll be writing and noting down how the baby is growing. So sometimes the mother might not understand if you ask, how is the development of the baby? So if you ask, are you happy with the red book? So if there is any problem, they will be writing in the red book. If there is no problem, then there would be no remarks on the red book. So if the mother is happy with the red book, that means the development of the baby is fine. So one more routine question is diet. So what is the baby having? So this is not only important to see if there is any gastroenteritis which might be happening because of eating outside, and it is also important what the baby is actually having. Is she breastfed or is she bottle fed? And finally, pee and poo. So is the baby urinating properly, and is the baby going to the loo as normal, or is there any difference in the pee and poo? So if there is any difference, so what are the differences you're looking for here? So in the urine, you ask for any changes in the color, changes in the smell. In the loo, you can ask any diarrhea, any blood in the stool. So those kind of things which might lead you to some diagnosis if you have not got any diagnosis before. So NAI. So why is NAI a routine question for all pediatric cases? So all these questions which we're discussing right now are general pediatric questions which you ask in every history taking. So why is NAI? So NAI as such, you don't have to rule out NAI in all the cases. So it's just a routine question to ask who takes care of the baby. Right, so we can discuss about all the questions related to NAI when we go through NAI sections. Next. So now examination. So what kinds of examinations do you do in case of pediatrics? So first, whenever you take any child to a doctor, even for a routine examination or in case of any fever or any temperature or any problem, so as soon as you enter, they do a full body examination, head to toe examination of the child, and then the vitals. So general physical examination, which is the head to toe examination of the child, and then they check the vitals. So in this case, as the baby is already having some findings in the ear, like pain and redness in the ear, which is already mentioned in the task, so you do an ear examination as well. So now what investigations do you do for febrile convulsions? So as we discussed earlier, febrile convulsions is a diagnosis of extrusion, and this can be because of any feverish condition which the baby might be having. So in our case, the source of infection is ear, which we found on the task itself that the ear is red on examination. So this condition is otitis media. So that's the reason the child is having fever and then she got fits. So what do we do for febrile convulsions as such? So what treatment do you do? What investigations do you do? So investigations, so as it is febrile convulsions, it's just fits because of high temperature. There is no other etiology behind it. So we don't do any investigations as such in this case. So what about otitis media? So otitis media depends upon the symptoms which the child is coming to you with, and also is there any signs and symptoms which are worrying you. So what are the signs and symptoms which worry you? High temperature is one, signs of dehydration, and then if there is any discharge from the ear, which might be because of ruptured implant membrane. So if you have any of these symptoms and signs in otitis media, then you try to do something. So if not, as such, otitis media is a self-limiting condition which you don't give any treatment for. And so you don't do any investigations in this case, as otitis media is a self-limiting condition. So what would be the management? The management is just symptomatic. So reduce the temperature, give some fluids, and then observe if they're going to get any further episodes of fits. So then, for otitis media, as I told you, you're not going to treat in any way. So you might be thinking of, what about antibiotics? Why should I not be giving antibiotics? The otitis media, if the baby presents to you before 4 days and the symptoms are not worrying you, then you don't do any antibiotics in that case. So you wait till the 4 days, and even after the 4 days, the child is still having symptoms like fever or develops any further symptoms like any discharge from the ear or anything, then you immediately start them on antibiotics. So what is the antibiotic of choice? So it would be amoxicillin for 5 days. Right. Then if the child is, or in that case anybody is allergic to any drug, you obviously change the drug and to a different one. So in this case, if they're allergic to amoxicillin, then you give erythromycin or erythromycin. Okay, so antibiotics are usually considered only if your child has serious health condition, or if the child is less than 3 months old, or if there is bilateral otitis media, or if there is any discharge coming from the ear. So if none of these symptoms are there, so you don't have to be bothered. So it is a self-limiting condition. You just send the baby home and ask the mother to observe for any of these symptoms which you're seeing on the screen now. Okay, so now next, we go ahead with another station, which is non-accidental injury. So what is non-accidental injury? So any injury which is done intentionally and not by an accident, so this is considered as non-accidental injury. So who are prone at this non-accidental injury? Anybody who cannot protect themselves in any way. For example, children, elderly people, or any people with mental disturbances who cannot protect themselves or who cannot speak for themselves. So these people are prone at non-accidental injury. So now what injuries are considered non-accidental? So what can you expect? So there might be physical abuse, there might be emotional abuse, there might be sexual abuse, and there might be neglect. So in our case, non-accidental injury, we have a case of physical abuse. So let's discuss only about physical abuse now. So what types of physical abuse can you expect to happen in non-accidental injury? So you can expect fractures. So what typical type of fractures do you expect in non-accidental injury? So one, it might be multiple fractures. And what type of fractures? One is spiral fracture of the humerus, then multiple rib fractures, then multiple fractures of the metaphysis, which are called bucket handle fractures. So these are the common fractures which you see in non-accidental injury cases. Right. So, and physical injuries, apart from fractures, what you see, you can see burns, severe burns, scars, any hot water, hot oil, any bruises like finger marks on the cheeks, finger marks on the back. So all these things can come under non-accidental injury. So whenever you see something like that in the UK, always ready to suspect NAI. So let's go into the station. So we have referred to in pediatrics. We have 4 months old who is brought into the hospital by the mother. She noticed a swelling on the baby's arm. So X-ray has been done and a spiral fracture of humerus has been diagnosed. So talk to the mother and this is for management. So what's your clue for the NAI in this task? It's the spiral fracture of humerus. So that's your clue for for the NAI in the station. So what do you do now? So what are the steps you have to follow in a case of NAI? First one, so NAI, whenever you get an NAI station, so in the presenting complaint, so when you're elaborating, so you take history like presenting complaint, then elaboration of presenting complaint, then you go for past medical history, and then pediatric history, and then you go for your investigations, examination, and management. So when you get a case of NAI, so when you have a clue of fracture, so you don't take the history of fracture, so the NAI itself becomes the presenting complaint. So now you have to elaborate NAI and try to get some history from the mother to see how the fracture has happened. Okay, so what history consists of NAI? So you can ask some questions like how the injury has happened, and if the mother talks to you, if she says, she might come up with some story saying, okay, this has happened because of that. And if you know that this is a spiral fracture and the story doesn't match whatever the mother says, so that's one clue for you for non-accidental injury. And delayed presentation is another clue. So you ask in the history, so when did the injury happen and after how long did you get her to the hospital? So if the presentation is immediate, then it's fine, but if the presentation is late, then you can suspect NAI. So that's one more clue for your NAI. And finally, you ask, what did they do immediately after the injury? For example, if the mother noticed the swelling on the arm as per the task, so you ask, what did you do immediately after that? If the mother says, oh, doctor, I didn't know what to do, so I didn't do anything. So then that will be one clue for your NAI. But if she says, oh, doctor, I got very worried, but I rushed immediately to the hospital, I don't know what to do, so I just came to you. So then you can see the difference between the two statements. So the first one will be a clue for your NAI, and the second one will be a normal case. And the last one and the most important one is who takes care of the baby. So if the mother takes care of the baby, then you don't suspect NAI in most of the cases. But if the parents are not biological parents of the child, then you always suspect it to be NAI. So that will be one more clue for your NAI. So in our case, so the child is taken care by the mother's partner, who is not biological father of the child, when the mother is out for work. So then that triggers one more suspicion for you to call it a non-accidental injury. And also while you're taking history, just please be vigilant about the behavior of the mother, and if there is child, then the behavior of the child as well, because in any non-accidental injury cases, there will be some suspicious behavior from the parents or the child. So they might not be talking to you straight, they might be changing their stories different times, and they might not be giving you proper eye contact. So you should be vigilant about all these things when you're dealing with the case of NAI. So how should we go with the station now? So you have already got from your task that you've got spiral fracture of the humerus, and you know now what to take from the history. And so what to do? Disclosure, beginning if the mother asks. So if the mother is very worried and she just wants to know what happened, so you can disclose that the child has got fracture in the beginning itself. And then you can say, now let me ask you a few questions to find out how this has happened. And then you can start taking the history. Or if not, you can, if the mother is not insisting you too much, you can directly say, okay, let me ask you some few questions, and I'll come back to you and tell you what you have noticed. So yeah, as I told you, from the history you ask who looks after the child, partner, and whether he is biological father of the child or not, which is very important. And again, your same pediatric questions. How was the birth, immunization, development, diet, and BN2 and question for NAI. So these 5-6 questions are regular for all pediatric cases. So you need to ask after your history, after your past medical history of the child, you need to ask all these questions in all the pediatric stations. So now examinations. Again, after history, you go for your examination. Again, any pediatric case, GPE, head to toe examination, vitals. So in NAI, in NAI you look for ear and eye examination because as you're suspecting NAI, it's basically physical abuse. So children, they're very delicate. So whenever you move them or you hit them, there might be some retinal hemorrhages, which might happen, and also there might be some injury to the tympanic membrane if they are hit on the head or ear. So we always do an eye and ear examination and also musculoskeletal examination to see if there are any other fractures or any other bruises or injuries. Okay, so now investigation. So what investigations do you look for? So always remember, before you disclose NAI to anyone, even parents, even your seniors, so you should be very clear with what history you have taken and what investigations you have done. So you have to rule out some release before you come to a diagnosis that this is NAI. So for example, if you got fractured, like in our case, we always have to rule out if there are any bone problems from before. So you do protein blood investigations and bone profile. So what is a bone profile in blood investigations? The bone profile is calcium, phosphate, vitamin D, and ALT. So you do these investigations to see if there are any bone conditions from before. And also, you do a skeletal survey. So what is a skeletal survey? The skeletal survey is one way for you to have a look at all the bones of the body by doing some serial X-rays to see if there are any other fractures. So if there are multiple fractures, then you have another clue for the NAI. Right? So now what you do? So what is the final management? So now fine, you have suspected for an NAI. So what will be the management for that? So for now, first, in our case, we have got fractures, so we have to deal with the fracture first. So the child might be in a lot of pain. So first, the management always starts from the basic management first, which as a junior doctor, you can start without any guidance or supervision. So what is that? So you can start him on painkillers and you can refer him to a bone specialist or orthopedician for fixing the fracture. So those are the first things which you can do without asking anyone. And then you have to do something about the NAI. So what do you do for NAI? So you always take your senior support in disclosing and involving the next people for NAI management. So you always inform your senior about this, and he is the one who can diagnose it as non-accidental injury. And then you involve social services. So who are these social services? So social services can be child protection services, the local police, or some team from the hospital who can involve in the incident and they can investigate about the incident and they can see what exactly has happened, and depending upon the fault, whoever has done it, they will take necessary action. So if the parents might have done this NAI, then they will take away the child from the parents and then they will keep the child safe somewhere else. But if only mother is fine, but if only the stepfather has done this, then they would keep the child and the mother away from the stepfather. Right, so this is about NAI. So if you can go through your scripts, you have a much better idea how to proceed with the station from the beginning to the end. So now we have another station for head injury in children. So as soon as you hear about head injury, so what comes into your mind? So if it is a pediatric case, what comes into your mind? Yes, obviously the child might have been playing and she might have fallen down, might have got head injury. Second one, again the previous station, it could be an NAI. So the child has come, so let's go into the task first. So yeah, we are an F2 in pediatrics, patient 9 months old, fell from sofa, now the baby is fine, there is a bruise on the head. Talk to the mother and discuss about management. So here, as we can see from the cast, the child fell down from the sofa. And now you obviously have to take the history of fall. So how do you take history of fall? So there is a pattern for taking history of fall, epilepsy, and fits. So we have, and loss of consciousness, sorry. So we have same pattern of history taking for all these three cases. So let's go through the history taking bit. So for anything, for fall, fits, and loss of consciousness. So what do you ask in the history? So first one is, what happened before the incident? Second one, what happened during the incident? And thirdly, what happened immediately after the incident? So here, as soon as the mother comes to you, she got the child fell down. So now you take history from the mother. So you ask, what happened? Could you tell me what exactly happened just before the incident? So what are you looking for here? So you're looking for some medical causes which you might get from your history. So you're looking to rule them out one by one from your history. So you ask what exactly happened before the incident. So if the mother says, oh, I'm not sure, doctor, she was just playing and fell down, I don't know anything what happened before. So you come up with your ruling out questions. So for example, she might be having any headache, meningitis, any, for example, as we just saw, some ear infection or any chest infection, UTI. So you ask few questions about that. Was she having any pain, headache, or any pain in the ear, or any cough, or any problem with the movement of the neck, or meningitis? So you ask these few, and any cough or your pneumonia. So you ask these few questions if she has any of those, and if she hasn't got any, obviously proceed to the next one, which is during the incident. So you ask, describe what exactly happened when she fell down. So will be like, okay, doctor, I don't know what happened. I was not there at the most situation. I went after the incident happened. Okay, that's all right. That's not a problem. So next you ask what happened. You tell me what exactly happened after you went there. That means after the incident. So what are you looking for here? So one, any injuries, any drowsiness, any loss of consciousness, any fits, any vomiting. So these are the symptoms which you're looking for after the incident. So same thing with the fits as well. So if the child is having fits, you ask what happened during the fits and what happened after the fits. So you obviously look for loss of consciousness, any injury, especially injury to head, any vomiting, any feeling of sickness, any drowsiness, which might have happened because of the fall or fits. Okay, so we have taken the history. So now again, go for past medical history. So was the baby fine all this while? Any medical conditions? Any medication is she on? Any fever in the recent past? So basically just past medical history. And then you come to your pediatric questions, which are birth, development, immunization, and we and food. The next one. So during the fall, so what are the questions to ask? Any loss of consciousness? Any jerky movements? If yes, then you have to elaborate. If no, then you don't have to elaborate. So if yes, it becomes fits. So what you ask? Any tongue biting? Any rolling up of eyes? Any wetting herself, incontinence, fecal or urinary incontinence during the incident? And any injury that might have happened during the incident. So then after the fall, so again, as I told you, any sleepiness, any drowsiness, and if you get any injury, so where did the injury happen? So whatever positive finding you find in any station, you need to elaborate it. So it might be an injury. So for example, in this station, the child has head injury and there is a bruise over her head. So you need to elaborate it. So how big was the bruise? Was there any swelling? How was the child after the incident, after the injury? So you need to elaborate a little bit about the finding, whatever the mother gives you. So after the fall, you always ask about vomiting, sleepy and drowsy. So now before. So as I told you, we can go with before, during and after. So what happens now if you're following the station summary. You come with before, during, and after. So once you start with before, so you have too many things to rule out. So once you start ruling out all the questions, you might lose track of your history taking. So again, you have to rule out TDs after your presenting complaint. So presenting complaint elaboration is before, during, and after. So again, after that, you have to rule out the TDs. So what we try to do is, you try to ask from during the incident, after the incident, and then you go for before the incident to rule out all the TDs. So you can, now from here, you can ask all the questions, you can rule out all your TDs, everything in one place, and then you can go to your past medical history. So you ask for any fever, any rash, any photophobia, which is for meningitis, any sweating, color, or whatsoever is shock. And then again, your general pediatric questions. So now the examination. So any patient, even an adult or pediatric child, whoever comes to you with a head injury, so what will be your first assessment? So whoever has a head injury, you are in END, so when they have come to you, what will be your first assessment? So your first assessment should always be anyone with head injury, loss of consciousness, or anything. Your first assessment will always be GCS and general physical examination. So you look for any other injuries, any bleeding anywhere, and because of the fall, they might have injured and they might have bleeding, and always do GCS score if there is any injury to the head or any loss of consciousness. So we have in the station, we have injury to the head, so we always assess how well is the baby first. So if the baby is playful, she's fine, she's doing all right, so you don't have to do GCS. But if the baby is not doing fine, and that's her first presentation, you always do GCS. So in our case, the GCS of the child will be 15 out of 8. And then obviously you check the vitals and do some neurological examination. So now, you have done everything. So what would you be looking at now? What strikes in your mind? If a patient has come with head injury, I've taken the history, I've done the examination now, so what should I be doing now? So what's your concern here? First and foremost, main, so we have, as mentioned with us, she had an injury and she had a bruise here on the forehead. So now what's on your mind? So you always see whether I should admit the patient, or I should do a CT scan, or I should observe the child, or I should send her home. So these are the 4 general questions which gets in your mind if it is just a simple playing child comes with a head injury. So if she has any fever or any other thing, so you obviously have to admit, and then you search for the source of infection, you treat, and then that's a different issue. But here she's just playing, she fell down from the sofa, so everything is fine. So now these are the things which comes into your mind, that do I have to do a CT scan or not? Whether I have to admit the child, or do I have to just observe and send the child home, or I can directly send her home without doing anything. So these are the first and foremost things which gets into your mind. So from the examination, you found out that GCS is 50 out of 15. Patient child is playful, she's very happy, no problems whatsoever. So the bruise is just 1 or 2 centimeters long. And so these are the findings which you got from your examination and from your history. And there is no past medical history, no current medical problems, nothing. So now, so what we thought, so first one, whether admit or not, second one, whether to do a CT scan or not. So firstly, CT scan. So there are some criteria to do a CT scan in children, so which would be, so first thing is injury. So if the injury is to the head and if the bruise is more than 5 centimeters, you do CT scan. And then vomiting. After the incident, if the child is vomited, in children, so adults there is different criteria and children there is different criteria. So if the child vomits more than 3 times, then you do a CT scan. If there is any loss of consciousness more than 5 minutes, you do a CT scan. If there is any focal neurological deficit, any weakness in anywhere, any facial group, any slurring of speech, so any of these things, you obviously do a CT scan. This is within the first 2 hours of the incident. Yeah? So if anything happened after the 2 hours, so for example, we GCS is less than 14 out of 15, you do a CT scan. But after 2 hours, even if the GCS is less than 15 out of 15, you do a CT scan. And if the child vomits even once, you do a CT scan. If the child gets any fits after 2 hours, you do a CT scan. So before 2 hours and after 2 hours. So there's criteria, everything is there, the material. You can just go through those. Then, so now, for example, now what we have to decide is whether we have to do a CT scan in this child. So first thing, injury is less than 5 centimeters. So no. Secondly, vomiting, the child has only vomited once from the history. So if it is more than 3 times, you do a CT scan. So no CT scan now. And she doesn't have any focal neurological deficit. She's playful. She's fine. And her GCSE is 15 out of 15. So you don't have to do a CT scan. So now next question would be admit or no admit. So as the child, everything is fine. GCSE is 15 out of 15. CT scan not needed. So any child who comes to you with a head injury, so you always observe them for 4 to 6 hours in the observation unit. Because as we spoke, after 2 hours, anything happens, you have to do a CT scan again. So that's the reason why you keep them in the hospital for 4 to 6 hours, observe them. If nothing is happening, then you always send them back home. Obviously, anything happens, you do a CT scan and you admit the child. So in our case, there's no need for CT scan, no need for admission, just admit, observe for 4 to 6 hours and then send home. So tell the same thing to the mother, that will be observing the child for 4 to 6 hours and then we will send her home if everything is fine. But meanwhile, if anything happens, we have to do a CT scan. Okay? And so regarding the admission and discharge in the UK, so you always have to keep everything in your mind that you should not leave the patient without any support when they are discharged from the hospital. So for example, here, if you are discharging this child, you should always ask the mother, is she able to take care of the child, or if she has any difficulties, or if she needs any help. The same way, any patient, when you're discharging, you always look their home circumstances as well and see if they need any help at home. Huh? For investigation, CT scan, as we just discussed, the management is just symptomatic and observation. So if the child doesn't have any symptoms, so you don't do anything for now, and just observe the child. So the criteria for CT scan within 1 hour would be suspicion for NAI. So if you get any kind of suspicion, NAI, you do a CT scan. Then post-traumatic seizure, no history of epilepsy. On initial assessment, GCS of less than 14, or for children under 1 year, GCS less than 15. And 2 hours after the injury, GCS less than 15, and suspicion of any facial skull fracture. And any focal neurological deficit, and for children under 1 year, presence of bruise, swelling, or laceration of more than 5 centimeters. Okay. So for children who sustain head injury and have more than one of the following risk factors, a CT scan should be performed within 1 hour. So what is that? So as I told, loss of consciousness or fits, which is lasting more than 5 minutes, abnormal drowsiness, and 3 or more episodes of vomiting. And any dangerous mechanism of injury, for example, if it is an RTA or any fall more than 3 meters height, any amnesia lasting more than 5 minutes. Children who have sustained a head injury and have only one of the risk factors should be observed for minimum of 4 hours after. So as we spoke, so you always observe for 4 to 6 hours and then you discharge the child home. So as again we spoke, so if during the observation, if anything happens, you do a CT scan within 1 hour again. So what are those? GCS less than 15, any single episode of vomiting, any further episode of drowsiness. And so what's the next station? So this is intussusception. So what is intussusception? Telescoping of bowel into one another like this, like as a telescope, which is say on the screen. which would be a better way to explain for your patients. Because whenever you explain to your patient, it should always be in simple in language, no complicated words or no medical jargons. Okay, so what is interoception? Telescoping of vowel into one another. So what's the task here? You are left to in pediatrics, 20 months old child brought to the hospital with abdominal pain by her mother. GP letter, abdominal discomfort, looks pale, peripherals are cold, looks lethargic, abdomen not distended, and there is a mass in the right hypochondrium. The blood pressure is 90/60, pulse is 140, respiratory rate is 28. Talk to the mother and discuss the management. So from here, what does it look like? It looks like there is some problem in the abdomen. So now, as soon as you go into the cubicle, you ask, there will be a mother, child won't be there, child will be in the next room, will be taken care by your nurse colleague. So now, you take history from the mother, diagnose what it is. So how do you take history? Again, presenting complaint, I know what exactly happened. So the mother will come to you with presenting complaint of crying. So what are the signs and symptoms of interoception, for example? So there will be crying, there will be tummy pain, there might be vomiting, and there is diarrhea with blood. So these are the major symptoms of interoception. Right, so tummy discomfort, crying, passing loose stool, and vomiting. So as we spoke, whenever any patient gives you any positive sign, symptom, medical condition, medication, family history, or personal history like smoking or alcohol, you always have to elaborate it. So this would be history station. So whenever you're in the history stations, any positive sign, you have to elaborate. Any positive symptom, you have to elaborate. Any positive medical condition from past medical history, you have to elaborate. Any medication they are on, you have to elaborate. Any family history, you have to elaborate. Any smoking alcohol history, you have to elaborate them fully. So just remember one thing, no patient will give you any clue. That means positive answer unless and until it's relevant to the station. So they always give you some relevant information as a clue. So you always have to pick it up. And so whenever you enter the station, the mother will be starting with, doctor, my child is crying. So you have to elaborate crying. So how do you elaborate? Crying. Always again, since when is the child crying? So that's the first question, because you have to know since when is the incident happening. So always elaborate the pattern of the crying. So what is pattern of crying? So is the child crying all the time or in breaks? So if it is in breaks, for how long does she cry and for how long does she be quiet? And also how is the child in between the crying episodes? We have to elaborate full pattern of the episode. So what would be the pattern in this case? So as it is in relation to the intestine, you always have episodic crying. So that means the child cries for some time, then child will be normal for some more time. So as we are elaborating, so for how long the child will be crying? The child will be crying for 2 to 3 minutes. And how long will the child be quiet? So around 20 to half an hour, the child will be quiet. And how is the child in between the cries? So the child will be very lethargic, very drowsy, very tired because of crying. Right? So now we have elaborated crying. So the next question would be, so always presenting complaint, and the next question would be anything else. So you ask, is the child having any other symptoms? Now the child, mother will come up with loose stools. So you ask, could you describe? So again, elaborating loose. As soon as the mother gives you some symptoms, you have to elaborate it. So how do you elaborate stools? And both vomiting, so we discussed both at the same time. So how do you elaborate them? When did it start? Number of episodes, color, quantity, any blood, and in relation to the food. So is it immediately after the food or vomiting? Alright, so and there are some localizing symptoms which you can ask for pediatric cases. For example, so if any child has pain, any child under 2 years, they cannot tell you that, oh, mom, oh, dad, I have some pain here, I have some pain here, here. So they cannot tell you. So that's the reason why there is something called localizing symptoms. So what are these localizing symptoms? So for example, I've seen of a bowel convulsion station, the child is pulling her ear. So what is that? It's a localizing sign for pain around the ear. And in this case, when the baby is crying, the localizing symptom which the mother tells you is the child is pulling her legs towards the chest. So what does that mean? So that there's some problem in the tummy. So these are the localizing symptoms which you have to be vigilant about to know where the pain is. As the children, they cannot speak, they give you some signs. Right? Again, if the mother says any vomiting, then you always have to elaborate vomiting as well. So as soon as we have symptoms like diarrhea and vomiting, so you always have to be very, very, very careful about dehydration. Right? So which is more acute, intussusception or the dehydration, which can be more harmful to the child? Yes, so that's obviously dehydration, which is going to be more harmful to the child than with dehydration. So you rule of dehydration. So what are the questions you look for? So dry mouth, dry skin, drowsiness, tired, lethargic, and if the child is less than 1 year old, so you look for the fontanelles, sunken eyes, tearless cries. So you have a number of questions, so you can limit your questions to 3 or 4 for the time management. Then again, your pediatric questions, which are birth, immunization, development, diet, feed, and food. So everything is fine, but there is some relation with the immunization for this patient in particular, because so what is the cause of intussusception? So there is no definitive cause, but sometimes some infections in the gut can lead to intussusception. So again, some recent immunization jabs as well can cause gastroenteritis and in turn can lead to intussusception. So you ask, is the child up to date with all the jabs, and is there any recent they have given to the child? Right. So we already spoke about who. So mother told you here the child has diarrhea. Now you ask about V. So V is also important V is also very important for symptoms of dehydration. So that the child will not be urinating more, the urinary output will be less. So all these signs again give rise. And will show you that the child is very dehydrated. So now again, so after you finish all your history part, now you come to your examination part. Examination do you do again? Any child had to do examination, vitals, and here abdominal examination. What you can find there is you can find a mass of intussusception in the abdomen, which is already there in the task. That is the mass in the right hypochondrium, and the child is cold and clammy, which is a sign of dehydration. So, again, vitals. Vitals are also given in the task. So what is already given? Blood pressure is 90/60, pulse is 140, so which are in line with the dehydration. So no blood pressure, a little bit tachycardia because of dehydration. Right. So now investigations. Any dehydration, any patient with dehydration, you always do electrolytes as a routine, and you do urine investigation as well. So, as it is related to the abdomen and you found a mass in the abdomen, so you always confirm your diagnosis of intussusception by doing ultrasound scan. And if you see that the child is severely out of proportion to the signs and symptoms which they are presenting with, so that can be because of any rupture of the intestine. So you do an abdominal X-ray to see that. So if the child is not showing you severe signs and symptoms of any rupture, then you don't have to do an abdominal X-ray. just do an ultrasound scan to confirm the diagnosis. So now management. So what's the management for intussusception? I know everyone is thinking about surgeries, operations and all, but always basic management first, as we spoke. Reversing dehydration is the first and foremost thing which you have to do as an F2 doctor in the hospital. So we always give fluids first, painkillers, admit the patient, stabilize the patient, and then we go with the specific management for your intussusception. So what is the specific management for intussusception? So first thing, in the tube, taking all the contents before the intussusception, and then there's something called air enema, which is done for reducing the intussusception. So what you do in this, you put a flexible tube in the back passage, and in the X-ray room, you flush air into the back passage so that the obstruction will be relieved. So you can try it a couple of times, but if it is not successful, then you go for surgery. So what surgery do you do? So you go for lap surgery under general anesthesia. You go into the abdomen, you reduce intussusception manually, and if at all there is any complication, you do dissection and anastomosis. So if there is no complication, you just relieve it manually, close it, that's it, you're finished. But if there is any complication or there is any infection of the bowel, then you have to do dissection and anastomosis. So once the child, okay fine, once the surgery is done, or the child intussusception is relieved, so now what next? So when can the child go out of the hospital? So as you're doing any surgery to the intestine, there might be some mild vomiting, mild diarrhea, that's all fine. And as soon as the child is able to drink milk or eat well, she can go out of the hospital. So that might not be too late. So after the operation, we start feeding. After the baby starts feeling very well, that's okay. You always have to be warning the mother about complications which might happen because of the operation, and be vigilant about the signs and symptoms of these complications. And you have to ask the mother to come back to the hospital if she notices any of these complications. So pyloric stenosis, this is also a similar station compared to intussusception, but what's the difference here? So what is pyloric stenosis? Pyloric stenosis is the obstruction of gastric outlet because of thinning of the pylorus. So what happens in this? What is the major symptom in this? Vomiting, which is projectile, and which is seen immediately after the feed. So this is the major symptom which you can see in pyloric stenosis. So what's the problem now here? What's the presenting complaint? The presenting complaint would be vomiting. So now we have to elaborate vomiting. So episodes, quantity, contents, color, blood, timing of vomiting in relation to the feeding. So all will fit into your pyloric stenosis. And so what is the question here? So you are F2 in pediatrics, 6 weeks old baby has been brought into the hospital by the mother because of vomiting. Vitals pulse 140, respiratory rate 40, blood pressure 100/70, SATs 96%, temperature 46.8. Talk to the mother and discuss the plan of management. Associated symptoms, projectile vomiting, dehydration, and as I told you, whenever there is vomiting, whenever there is diarrhea, you always have to be careful about dehydration. And tummy pain, obviously, there is pyloric stenosis, anything related to the abdomen, there would be tummy pain. And poor weight gain, because this condition, what causes pyloric stenosis? So again, same here, there is no definitive cause for pyloric stenosis. And when is it seen usually? So it is seen in very early age of birth, so seen around 6 months of age, which is 6 weeks of age, sorry, which is very common. And this is the age when the child starts growing, and as there is stenosis and there is vomiting, the child vomits whatever the child feeds, so that is why there will be poor weight gain. Again, so after that, you go for your past medical history, so any history, whatever has happened before the incident, and then your pediatric questions, which are birth, immunization, development, and all. So these are the reading questions again you ask. So in this, what you're interested in is the diet. So breastfed, but whatever the baby is eating. Go to the investigations again here. So routine blood test. So ABG, why do you do ABG? As the child is vomiting everything, whatever, yes, there might be some electrolyte imbalances, so that's why we do ABG. So again, any invasive procedure in a child, we should hold back if the child is not severely ill. So if the child is severely ill, then you do this. If the child is severely not ill, then you obviously carry on with the symptomatic management. Then, as always again, ultrasound scan, anything in the abdomen, ultrasound scan to confirm your diagnosis. So what will be the management again? Same. Anywhere you see dehydration, you always have to rehydrate the child, so give fluids. Then there's something called test feed. So what is this test feed? So you feed the child in front of you, and you observe the child after the feed, for the vomit, and if there is any peristaltic movements in the tummy, which can give the confirmation of pylorostenosis. And then the definitive management for pylorostenosis would be surgery, which is pyloromyotomy. So what does this surgery involve? Again, same thing like intussusception, keyhole surgery, under general anesthesia. So what would we do here? You cut open the muscle fibers of pylorus and make the passage open. Again, same here. Even after the operation, for a couple of days, there will be slight vomiting, which is normal, and the child should be better by the child after 2 to 3 days usually. So you have to be informing the mother about these things. So child will be vomiting for 2 to 3 days, which will not be severe, but there will be mild vomiting, so you should not be worried that part. But if the vomiting continues even after 3 to 4 days, then you have to get your child back to the hospital. Yeah, I can see him here as well. As soon as the child is feeding well, she can go. So now the next station is epilepsy. So as we spoke, epilepsy fits our history here. Before during I get some information during what type of instant. And then after are you looking for? Retrograde amnesia or anterograde amnesia, drowsiness, any further fits, drowsiness, any loss of consciousness after the incident. So this is how we take the history for epilepsy. But here our station is a bit different. So we are not taking history for epilepsy, but we are discharging a patient who is already diagnosed with epilepsy. So you are active in pediatrics, patient age 10, presented to the hospital with fits, and the diagnosis of epilepsy has been made already. So she has been medically managed and is fit for discharge. The neurology consultant has prescribed her some medication. Mother has some concerns. Please talk to the mother and address her concerns. So what do you do in this station here? So the patient is already medically fit, diagnosed with epilepsy, prescribed some medication. Now you have to go talk to the mother and address her concerns. So what do you expect to be there in the station? So as soon as you went to the station, so first things first, you always have to assess her condition now. So how is she doing now? So how is her fits now? Is she getting any other episodes? Is she feeling well? Any neurological deficits? Nothing. So everything is fine. So first you have to assess her condition. Then you have to discharge. So while discharging, you have to remember three things in mind. So always, for discharging any patient, you should be medically fit first. Then you should be explaining their medications when they are going home and any necessary precautions which they have to be following after they get discharged. Alright, so let's go to the session. So review patient present condition, explain the medication. So the mother's concern, so swimming and dancing, we'll come back to that in a bit. Yeah, so this is routine for all the sessions. So reviewing the present condition, explain the medication. But for epilepsy, what are the precautions you want to talk about? So the precautions would be, so one is trigger factors. You always have to talk about the trigger factors. So as I told you, your job in the UK is not only to tackle in the hospital and send them out. The job is also to support them in the community after they get discharged. So that's the reason why you always keep giving advices, follow-ups, one at a time. So all these things you always try to give them because you always have to support them even after they get discharged from the hospital, and you have to follow them up as well once they are discharged. So that's the reason why you have to explain the trigger factors, try to find out the trigger factors if there are any, and then try to avoid them. So if you avoid the trigger factors, then the chances of getting fit is very, very low. So that's what they believe in here. So that's the reason why you always have to explain about trigger factors. And then what to do if any fits happen next. And what are the general precautions which you have to follow in day-to-day life? That means living everyday life with epilepsy. So because as the child has got epilepsy, the mother might be concerned about how will she lead a normal life? Will she be able to lead a normal life like all the other children? So these are the concerns basically every mother will have. So you have to sort them all out. So for example, you review the patient's present condition, she is fine, she doesn't have any symptoms, she's doing all right, she can go home. So now we have to explain about the medication. So what is special about explaining epilepsy medication? So epilepsy medication you have to take as prescribed. So as prescribed, not only epilepsy of course, but any other medication you have to always take as prescribed. So you have to explain that you have to take them as prescribed and you should not miss any dose. And as this is epilepsy medication, this takes some time to build up therapeutic level in the body. So that's the reason why even if you get fits in the initial stages of taking medication, you should not stop taking the medication. So these are the precautions which you have to give regarding medication. So one, as prescribed. Two, not missing any dose. So even if you get any fits in between, you should not stop epilepsy medication. You should continue taking them. So these are the three things about medication. The next, we're talking about trigger factors. So what could have caused epilepsy or what could trigger your epilepsy? So what are the conditions which can trigger? Dehydration. So you have to ask the mother to hydrate the child well. Skipping meals. Sitting in front of the TV screens, laptop, mobile screens for a long time. Exercises. Excessive exercises can cause epilepsy and fits. So excessive exercises when we take, so the child is going for swimming and dancing classes. So we have to deal with them after all this exercise. Excessive exercises, loud music, flashing lights, any stress, any kind of stress. So child is going to school, so you have to address about stress at school as well. And so these are some of the trigger factors which might induce fits. So from here we got the child is going to school, so you have to mention about stress at school. So try to avoid any stress at school. If there is any problem, always talk to your coordinator who will be understanding. Then about swimming and dancing classes, you have to mention you have to be extremely careful when you are around water or if you are doing any activities in the water. So you mention the child, the mother, that you always inform lifeguard. So there is a lifeguard in every swimming pool across the UK. So you have to ask the mother to inform the child, inform the mother to inform the lifeguard about the child's condition so that he can be extra careful about that child and he knows what to do to the child. And then we always try to swim in shallow areas and uncrowded timings. So try to go to the swimming pool when there is less crowd, and always try to remain in the shallow areas, don't go to depths. And dancing, so as long as the dancing classes are not extremely stressful and there is no loud music, so as we spoke, loud music and flashing lights can also cause epilepsy. So as long as there's no loud music and excessive stress, you can continue dancing as usual. But you have to inform the dance teacher about the condition and what to do in case we develop an epilepsy. So these are the concerns which she has. So now, what are the precautions which they might have to take when the child develops next phase? So what should you be doing when any child develops phase? We have to put them in the recovery position, remove any sharp objects around them, don't put anything to the mouth, and immediately after the fix, bring the child back to the hospital. And if any medication is given, we have to give the medication. Right. And how to lead a life with epilepsy now. So how do you lead a life? So you have to inform the mother about the precautions that should be followed at home, like avoiding sharp furniture, slippery floors, and when you are taking bath, so it's always better to do shower instead of baths, because if the child develops any epilepsy during bath time, then it will be difficult. And always try to avoid locks to the washrooms, and just try to put some engage signs or anything. So these are some of the measures, and always try not to send the child alone, try to accompany. And we also give something called epilepsy card to all epilepsy patients so that they can carry it with them. Epilepsy card is like a credit card this size, so they can carry it with them anywhere they go, so that people around them can know in case of emergencies. Alright, so let's go. What are the risk factors? Lack of sleep, flashing lights, loud music, recreational drugs, skipping meals, dehydration, stress. So as well, all this can cause trigger factors. So general advice, use guards on radiators and heaters, cover any sharp furniture edges, take shower instead of bath, wear epilepsy bracelet. So yeah, epilepsy card or epilepsy bracelet. Epilepsy bracelet, you can wear it on the hand, which informs that you are epilepsy patient and you're on epilepsy medication. So the epilepsy medication which we give is sodium valproate. So if the mother asks, and if you have time to in the station, you can always discuss about some side effects of sodium valproate. So what are those? Nausea, gastric irritation, diarrhea, weight gain, increased ammonia level, and hair loss. Okay, so let's take a quick 5-minute break and then come back to our stations. Thank you.
We can discuss. Okay, guys. Simple. I think we are, to be honest, I think we are overthinking on it and wasting time. To answer your question, I probably getting over it. You asked me, you're the doctor, you're the patient, I'm the doctor. You could be telling me about it. Have you thought about doing this in the past? I understand the situation is a bit volatile at the moment, but because it will be a bit difficult to in the past. But anyway, let's see what we can do now, right? For the past treatment, maybe I give a different scenario there, whatever you feel comfortable with. Okay, guys. So, I don't know how many times I've told you. I'm not going to tell you what you're supposed to do. I'm just telling you this is what the thing is, whatever you feel naturally. You want to acknowledge it. You want to ignore it. Okay. The only thing I'm highlighting over here is that do whatever you want, don't laugh. That's it. It is as simple as that. Okay. we have wasted 10 minutes just going into the circle the same way. It's okay. The only highlighting part over here is that don't react now. Okay? What was the golden rule number 1? Be punctual. Right? What if you, and when I said when you start working, if you work start at 9, try reaching there by 8:30. It's creating good impression. Right? What will happen if you're coming late? Exactly. If you're going to come late, inform. But will it be like you'll inform every day? It does not look good, right? That you're informing every day. How would you, address if a person is coming late every time? You have to talk. Let's suppose you are getting class. Okay? I'm giving you every 10 minutes, and every session I'm giving after that, I'm giving 10 minutes break. So you're coming late every time. Okay? Or rather, let's switch. You are the teacher. I'm coming late every 10 minutes. And every time after the 10 minutes break, I'm coming late. And now you have to address that. How are you going to do that? Now the thing is this, that I feel really humble every time you do that.
Hello guys, I'm back. So yeah, let's go with the rest of the station. So the next one is flu jab vaccination. So have you guys, any of you guys in your countries have given flu jab to children or in your vaccination schedule? No, I haven't given in my country, so let's learn about it. So yeah, the station here. So your next to NGP 3-year-old child Luke is due for flu vaccination in 1 week. Mother wants to talk to a doctor. Talk to her and address her concerns. So always remember where you are, which is very important. So whether you are in GP practice or A&B or clinic or department. Right, so you are in the GP here. So always remember whenever you have a GP station, that means that's not a serious station. That means not an emergency, which will have mostly counseling stations. But if you have an A&D station, then there will be serious cases which you have to treat. So let's go inside. So what is this flu vaccine and what are the concerns here? So who should be immunized? So what is flu vaccination for? So vaccination against flu virus, influenza. So this is given to all the children under 8 years of age, pregnant women, and elderly people above 65. So what are the side effects and contraindications? So side effects would be fever, rash, and contraindications would be encephalitis, seizures, vaccine allergy, or egg allergy. So people who have egg allergy, so we won't give flu vaccination. So where can you get this flu jab in the first place? So where and when? So when is after every September till February. The NHS here, they give you flu vaccination and you can get it at your local GP or local pharmacy or midwife can give for pregnant women. Okay, so you can get it in those places and you can get it from end of September till January, sometimes till February when there is flu going on. Okay. Okay, so what's the concern about this flu vaccination of mothers? So they think the flu vaccination by itself can cause some complications and they have some worry that the flu vaccination might itself give flu. So you have to make sure, you have to clarify to the mother that this vaccination doesn't have live viruses, so it doesn't cause flu and it doesn't cause, it is proven not to cause any complications like encephalitis or anything. So these are the most common concerns the mothers might be having, so which you have to reassure them that something is going to happen. So the same way like flu vaccine, we have one more vaccine called MMR vaccine. So what is this MMR vaccine? So MMR vaccine is measles, mumps and rubella. So what is the concern here? So let's see the task first. So again here, so as I told you, all the GB cases are not so serious and just for counseling. So we are on F2A GP surgery. So 12 months old child is due to be given her MMR vaccine. In the next 2 weeks, child's mother presented to the GP surgery to discuss about her daughter's MMR vaccination. We haven't seen Jenny since birth, so the child's name is Jenny. Please talk to the mother and address her concerns. So it is a non-emergency visit. So yeah, so what about this MMR vaccine again? So what do we have to know? When to give? What does it cover? How is it given in the NHS? And where is it given? Again, any complications? And what are the concerns the mother might have in the UK? So let's go. The first dose of, so it's given in 2 doses usually. So one is at the age of first birth, so that means 12 or 13 months old, and the second is usually at school going age, which is 3 years and 4 months to 5 years. So 2 doses, and it is given in 1 single injection. So it's given in 1 single injection in the NHS, so it's not given separately. And what would be the mother's concerns in this patient? So what does it cover first? So measles, mumps and rubella. So what would be the side effects of this? So you might get mild form of mumps, measles and rubella. So measles, you get fever, rash, dehydration. Mumps, glandular swelling. Rubella, muscle pain, joint pains. So these mild forms you can get, which might subside in a couple of days. So you don't have to worry about it. So you have to be reassuring if the mother has any concerns about side effects of this vaccination. So again, it is live attenuated vaccine. And so the mother has a concern. So first thing is, there is a study which happened not so long time ago, about 25, 30 years ago, about MMR vaccine and autism. So the study published that MMR vaccine can lead to autism and autism spectrum of disorders, like bowel disorders. So the study proved that, and that notion was going on in the UK since then, and all the mothers are a little bit worried about giving MMR vaccine to their child, thinking their children might get autism. So you have to reassure the mother in a confident way that MMR vaccine does not cause autism. So the study which has happened before and which the rumor was going on, that study was proven wrong. And after that, there were many studies conducted based on the same study, MMR vaccine and autism in children. So none of them proved that MMR vaccine can cause autism. So that's the reason why you don't have to worry about it. You can safely give the vaccination. So whenever you say this, the mother still can't get convinced, and she wants to somehow try avoid MMR vaccine for a child. So she might come up with saying, so are these mumps, measles and rubella common in the UK? We are a developed country. So again, you have to tell the mother that, so yeah, it might not be prevalent in the UK, but there's always a chance of outbreak. And moreover, people from outside can come into the country with the condition, or you might travel into other countries where this condition is prevalent. So vaccination is very important. So once you cover all the concerns of the mother, you can just take a brief history to see if there are any contraindications for the child. So for example, if there is an acute infection, you delay this one, and if you delay the vaccination. So if there is an immunocompromised state, so you don't do this vaccination because this is live attenuated vaccine. vaccine. So you take a brief first medical history to rule out those contraindications and see whether the mother is willing to give the vaccination or there with the MMR and flu jabs. So now there is one more station called fluid prescription. So this is a station where the doctor in surgery department, child has come to you for surgery of his appendix and he's going to have surgery today. So what you're going to do now, so any patient who's going to have a surgery under general anesthesia, you keep them on nil by mouth. So when any patient is nil by mouth, what you give him some fluids, right? Dextrose. So that's what you're going to do now. Yes, so you are an F2 in surgery, patient 86, diagnosed with appendicitis, as we said first, and child must be kept nil by mouth. So prescribe IV fluid. Child's weight is 25 kg, so you have to prescribe sodium chloride 0.9% with 5% dextrose. Talk to the parent, address the concerns, and prescribe the fluid. So explain the necessity of the fluid and explain the type of the fluid. So what is the necessity here? So the child has to be kept nil by mouth, so it needs energy. So that's why we have to give this fluid with dextrose. So what is the type of fluid? So it is sodium chloride mixed with dextrose, so sugars. And again, so after that, again always whatever you're giving, any new fluids, drugs, medication, anything, whatever you're giving in the hospital, you always have to take a brief past medical history to rule out any contraindications for that one. So what would be the father's concerns here? So he would be concerned about, same again, why are you giving this medication? Why are you giving these fluids? What does the fluids have? And how are you going to calculate how much my child needs? So there is a table which tells you how to prescribe fluids in children. So it will be the first 10 kgs will give 100 mils. For the next 10 kgs you give 50, and after that you give 20 mils per kg body weight. So you have to remember the numbers and then calculate according to the weight. So the child is 25, you calculate as 10, 10 and 5 kgs. Then tell the father that we are going to calculate according to the weight like this, and then we are going to prescribe the fluids. Yes, so first 10 kgs, 100 mils per kg, next 10 kgs it will be 50 mils, and the next 5 kgs it will be 20 mils. So totally 100 into 10, 1000, 50 into 10, 500, and 20 into 500. So total fluid in 24 hours you're going to give is 1600. So how much will be per hour? 67. So this would be the calculation rate. So first 10 kg is 100, next 10 kg is 50. Above 20, it will be 20 mils per kg per day. Okay, so you'll have this fluid prescription chart. So in NHS, we have drug chart. So in the drug chart, we have separate columns for everything. So we have separate column for antibiotics, we have separate column for oxygen, we have separate column for regular medication, we have separate column for PRN drugs, we have separate column for stat doses, we have separate column for IV fluid prescription. So this is that column where you prescribe IV fluids on the drug chart. So you have to mention the date, what is the infusion fluid, how much volume you have. So it's a 500 ml bag. The name of the drug to be infused, so you're not infusing any drug into the bag, so you don't have to do it. And dose of the drug, so you're not adding any drugs, so you don't have to follow the drug. So route will be IV, infusion rate would be 67 mils per hour, and then you sign it. So this is how you prescribe fluids in the NHS. Then the next one would be neonatal jaundice. So neonatal jaundice, so what is jaundice? So as we know, increase in bilirubin level in the body. So this might be because of many causes. So mainly in children, 24 hours to 15 days is usually neonatal jaundice. It is usually uncomplicated. That means nothing to worry about. So there is physiological jaundice, there is breast milk jaundice, there is breastfeeding jaundice in neonatal jaundice. Same, so anything before 24 hours and after 15 days you have to be worried about. So why do you have this jaundice in children, so which is very common in children. So in children, there will be a lot of RBCs which will be recycled every day. So any lysis to the RBC cells will give rise to bilirubin, which will be conjugated in the liver and then eliminated. So what happens in children is the liver will not be matured to full extent in the initial 2 weeks of age. So that's the reason why they won't be able to eliminate that amount of bilirubin. So that's the reason why you see jaundice very commonly in neonates. Let's go with the task. So you are an F2 in pediatric ward. This is Laleh Hussain, the mother of a 15 days old child, referred to the pediatrics ward by midwife. The weight of the child is 3.7 kgs to the top of the mother as a child and keep the initial plan of management. Alright, so physiological jaundice, breast milk jaundice, and breastfeeding jaundice. So what is physiological jaundice? So physiological jaundice is, as I just told you, so the child will be unable to eliminate the bilirubin produced because of the RBC turnover in the initial stages of life. So this usually is seen in around 2 to 3 days of life and will usually be settled in first week of life. Right. And breast milk jaundice. So breast milk jaundice is when the child is feeding with breast milk. So this is usually seen in children 2 to 3 weeks of age and it is there till 12 weeks of age. So even that is nothing to be worried about unless and until the bilirubin level is very high and needs to be treated. So what is breastfeeding jaundice again? So breastfeeding jaundice is where the child is not getting enough breast milk in the initial stages of life. He might develop breastfeeding jaundice. So this can again last 3 weeks of life. So symptoms: cellular discoloration of palm, soles, mouth, abdominal distension, nausea, vomiting, diarrhea, and constipation. There might be itching as well. So management would be, so we always again examine for all the scale for LOH discoloration, examine the tummy and do liver function tests, especially bilirubin, direct and indirect. So treatment would be conservative mainly. So you have to continue breastfeeding even if there is jaundice, because the benefits of breastfeeding outweigh the jaundice by itself. So unless and until the bilirubin levels are very, very, very high and needs treatment, you don't have to do anything, just conservative management, continue breastfeeding. And if the treatment is needed, then it would be phototherapy and exchange transfusion. So how is phototherapy done? So the child is put in a tube where the UV lights are poured on the baby's skin and the bilirubin is broken into oxidized, the bilirubin is oxidized, which can be easily eliminated by the liver. So exchange transfusion again, so some amount of blood is taken from the child, baby, and then we infuse same amount of blood from a donor. So in this way, the blood will be diluted and the bilirubin level will be. So these are the two procedures which you do to treat jaundice if it is symptomatic or if the bilirubin levels are too high. So in the station, you might get bilirubin level around 10 mils per kg. So you actually don't need treatment till it is 18 mils per kg or above. So if it is 10, it's fine. You just do conservative management and continue breastfeeding and observe the child for any severe symptoms.